Hi, my name's Austin Meulman. I'm one of the RMOs at Nepean Hospital, and I'll be giving you a talk on anemia. So here's a brief overview of the talk. First of all, I'll discuss the background of anemia, as well as the symptomatology, then give you a brief breakdown of the different types of anemia, then go into each one in a little bit more detail. Finally, I'll give a brief mention of transfusion medicine, and then finally ending on a case presentation. Anemia is defined as a decreased concentration of hemoglobin. However, the exact number can be very variable depending on age, sex, elevation of residence, smoking habits, and pregnancy status. In conjunction with this, how patients will actually present is also highly variable. Finally, it's extremely common, with the World Health Organization estimating that around 42% of children less than 5 years of age and 40% of pregnant women worldwide are anemic. As mentioned previously, there is a very broad spectrum of the symptoms that patients may be experiencing. And while this table only provides a rough guide of the symptoms patients might experience at different hemoglobin levels, it highlights the variety of clinical presentations that you may come across in your practice. Now, we'll be looking at an effective method of approaching anemia. While this is a very busy slide, the main point is that the initial differentiation of causes of anemia is through the MCV, or mean corpuscular volume, where less than 80 is considered a microcytic anemia, 80 to 96 is considered a normocytic anemia, and greater than 100 is considered a macrocytic anemia. Furthermore, it is also worthwhile noting that there is some interchangeability within this table. For example, Haemolytic anemia, which is listed as a normocytic anemia, has a potential to become a macrocytic anemia over time as larger reticulocytes are formed. So, starting with microcytic anemia, the most effective way of differentiating the various causes is through obtaining iron studies. Major components of this include serum iron, ferritin, transferrin, and transferrin saturation. Serum iron, while not much use as a single number, it is useful in determining the transferrin saturation, and it can also be used in the setting of iron overload states such as sideroblastic anemia and thalassemia. Ferritin is used as a good indicator for the total iron stores of the body. However, it needs to be interpreted in the context of the rest of the results. As in patients with anemia of chronic disease, this will actually be elevated. However, there is a relative iron deficiency due to the reduced amount of transferrin present in the body. Transferrin is an iron transport protein. This is a proxy for the total usable iron in the body and is commonly increased in the setting of iron deficiency anemia in an attempt to meet the requirements for cellular production of hemoglobin. Finally, transferrin saturation indicates the binding capacity of the transferrin protein, and again is another proxy for determining the iron levels in the body. Furthermore, it's important to note that other causes of microcytic anemias like thalassemia and sideroblastic anemia often will require further diagnostic tests with hemoglobin electrophoresis and bone marrow biopsies respectively. So once you have differentiated what is causing the anemia, it is able to be much more effectively treated. So within the setting of anemia of chronic disease, it's important to identify what the chronic disease is and then treat this. In iron deficiency anemia, this can be treated with iron supplementation. Sideroblastic anemia is trying to identify what is causing this and then consider administering pyridoxine or thiamine. And finally, with thalassemia, depending on whether it's a major or minor, it may not actually require treatment or potentially can be transfusion dependent.
When considering normocytic anemia, the two major causes include acute blood loss and hemolysis. For acute blood loss, it is important to assess for all bleeding that may have occurred. This includes any occult bleeding following any trauma or gastrointestinal bleeding, which may manifest as PR bleeding, hematemesis or melena, or more gradual blood loss, which may be subclinical, such as in submalignancies. Hemolysis also has a variety of causes and will often manifest with symptoms such as fevers, rigors, tachypnea, and in some cases also pigmented urine. When considering this, it is important to order what is known as a haemolytic screen, which includes a reticulocyte count. It is the number of red blood cell precursors, LDH level, as well as a bilirubin level, which are breakdown products of the red blood cells, and finally a haptoglobin level. And haptoglobin is a protein that binds to the hemoglobin protein released into the bloodstream. It is the reticulocyte count, LDH level, and bilirubin levels which will all increase in acute hemolysis, and only the haptoglobin level which will decrease. Once you have determined the presence of a haemolytic anemia, subsequent testing is required to determine the exact cause, with a different testing method being used for each disease process. Sickle cell anemia, which is more commonly seen in countries endemic with malaria, is best differentiated on a blood film, such as that which is pictured in the top right. Glucose 6-phosphate dehydrogenase deficiency, or G6PD deficiency, is very different from glucose 6-phosphatase deficiency. In glucose 6-phosphate dehydrogenase deficiencies, patients lack the enzyme that is used in the production of NADPH, making their red blood cells much more susceptible to oxidative damage. Classically, the acute hemolytic events are associated with eating fava beans, though it can be caused by any stress reaction, most commonly due to infections. In patients that this is suspected, G6PD levels can be assessed, though it is important to note that these may be falsely normal in the acute setting. Hereditary spherocytosis will often have a familial history, and the destruction of red blood cells is often facilitated through splenic sequestration. This can be diagnosed on a blood film or also through osmotic fragility testing. Finally, autoimmune causes of hemolytic anemia are best diagnosed through the Coombs test, which has two components, the direct and indirect. The direct Coombs test uses the patient's red blood cells, which attempts to identify the antibodies attached to them, and in the indirect Coombs test, the patient's serum is assessed for the presence of red blood cell antibodies. There is a pictorial representation of the two different tests shown in the bottom right. The treatment of normocytic anemia, like all other kinds of anemia, is cause dependent. For acute blood loss, it is important to find the source of the bleeding and stop this, and transfuse as required. For autoimmune hemolytic anemia, often this is treated with steroid therapy. For G6PD deficiency, the best treatment is often to avoid potential triggers, then provide symptomatic relief in the acute setting. In patients with hereditary spherocytosis, they will often require a splenectomy with a vaccination for encapsulated bacteria such as pneumococcal and meningococcal beforehand. In sickle cell anemia, patients will often present in the acute setting with what is known as acute pain crisis or vaso-occlusive crisis, in which they will require symptomatic treatment with oxygen, analgesia, intravenous fluids, and hydroxyurea. In the long term, patients will often require regular blood transfusions, and as a result, they may become iron overloaded. So it is important to keep an eye out for this.
Macrocytic anemia is the last broad classification of anemia and is further subdivided into megaloblastic and non-megaloblastic anemia. The differentiation of the two types comes from the assessment of the peripheral blood smear to assess for the presence of any hypersegmented neutrophils, i.e. with greater than 5 lobes on their nucleus, with the the presence of large oval red blood cells. Types of megaloblastic anemia include vitamin B12 deficiency and folate deficiency, while non-megaloblastic causes of macrocytic anemia include liver disease, reticulocytosis, hypothyroidism, and different medications such as allopurinol. In the setting of megaloblastic anemia, vitamin B12 and folate levels are able to be tested. However, there is potential for the test to come back as equivocal, in which case a methylmalonic acid test will be required. If this comes back as elevated, this would indicate a B12 deficiency. Once you have determined what type of deficiency is present, you are then able to replace as required.
Now we will move on to a short talk about transfusion medicine. It is important to remember the criteria and indications for transfusion vary greatly depending on the hospital and/or the department that you are in. However, it is a good starting point to consider a transfusion for any patient who you think may be profoundly anemic. Furthermore, it is important to remember iron transfusions may be all that is required in patients with normal functioning bone marrow who only have a mild microcytic anemia.
The process of ordering packed red blood cells is important for any junior doctor to know, as if the appropriate steps are not followed, it can delay the whole process of giving blood to a patient who may be in significant need. The first step is to obtain a group and screen, which should be obtained with the initial set of bloods if a significant anemia is suspected. The next step is to consent the patient to the transfusion of blood products, which involves an explanation of the risks associated with giving the blood products, but also explaining why it's beneficial in their case. Next is to do a written order or an EMR order of the packed red blood cells, and the last step is to notify the blood bank, giving them the patient details, the indication, and the number of units required. Then you can also let the nursing staff know so that they're aware to call for the unit when it is ready.
When consenting a patient for a blood transfusion, it is important to educate them about the risks beforehand. The risks of blood transfusions can be broken into acute and delayed, as well as being immune-mediated and non-immune-mediated transfusion reactions. Acute immune-mediated complications include allergic reactions, which can range from being very mild, occurring in 1 to 3% of patients, where the patient may just feel generally unwell, to all the way to acute anaphylactic reactions, which are much less common. Also in this group is transfusion-associated lung injury, or TRALI, in which patients often present with profound pulmonary edema and hypotension, and has a very variable incidence. Acute non-immune mediated complications include transfusion-associated circulatory overload, in which there is fluid overload secondary to the transfusion, and is often associated with hypertension. Now, this is quite common, occurring in 1 in 100 blood transfusions. However, it is greatly dependent on the patient's age and cardiac function. Complications of massive transfusions are associated with being transfused with large amounts of blood products, often in the setting of a massive bleeding. And this is a result of a dilutional effect. If any of the above reactions occur, it is important to stop the transfusion and treat each complication as indicated. Delayed reactions are often missed and are much more difficult to pick up, as they can occur many days following the initial blood transfusion. Delayed immune-mediated complications include delayed hemolytic reaction, which often presents similar to hemolytic anemias, or transfusion-associated graft versus host disease, which primarily occurs in immunocompromised hosts. Delayed non-immune-mediated complications include iron overload, which is often a result of the patient being transfusion dependent, and over time becoming progressively more iron overload. Finally, when presenting these risks to the patient, it is important to give them some context in a way that they would understand, such as comparing them to the risks of being caught in the rain or the risks of being struck by lightning. So here is a brief case presentation. The setting is you're an intern working in a very busy emergency department, and you assign yourself to see a 30-year-old female who is triaged with a 1-week history of lethargy and lower back pain. Now, it's important to think about what you would ask her with regards to this presentation. With her back pain, you can ask her about the Socrates acronym, including the site, onset, and character of the pain. Furthermore, it is also important to ask all the red flags of back pain as well, including saddle weakness, urinary or bowel incontinence, fevers, unexplained weight loss, or any trauma that she might have sustained. Also, it is important to ask about any bleeding history as well, which is particularly notable in a patient of this age group and gender. Ask specifically about her menstrual history as well as any evidence of any GI bleeding. You can also ask about any other symptoms including postural dizziness, shortness of breath, or any swelling in the legs. Finally, it is also important to ask about how the patient was prior, making note of any other infective symptoms, while also getting an idea of how long she's been unwell for. On getting a further history, she mentions her shortness of breath has been getting worse over the last week, and she's starting to get symptoms of postural dizziness and just feeling generally more unwell. She denies any blood loss or any current infective symptoms, though mentions she just got over the flu yesterday, which she had for about a week. With regards to her back pain, she describes this as a dull aching pain with no radiation or no other red flag features. Finally, she also mentions that her urine has been a little bit more dark over this last week, though she put this down just to being a little bit more dehydrated.
Though she denies any past medical history, she mentions that often she has been feeling very washed out after getting similar kind of infections, however, not to the same extent that she is currently. She also mentions that her mother had anemia and often was requiring intermittent transfusions as well. In terms of her social history, she doesn't drink or smoke. However, she mentions that her family is from Africa and she's only very recently moved to Australia. So you decide to examine her and you notice that her blood pressure is quite low at 100/60 with a heart rate of around 95 as well. She does have some sclerolictris when you look into her eyes, and as well as a reduced peripheral capillary refill, though it is quite normal centrally. Otherwise, her examination is unremarkable with a normal chest and heart sounds, as well as an abdomen that's soft, non-tender, and no evidence of any peripheral edema. So you decide to do some blood tests. So these include a FBC, an EEC, group and screen because she is quite anemic, as well as a Haemolytic screen. She is profoundly anemic on the blood test with a hemoglobin of 65, however a Normocytic anemia with an MCV of 98. Her white cell count's mildly elevated at 11.2, however she does have a positive hemolytic screen with an elevated bilirubin of 340 with a reticulocyte count as well of 12. You also do a peripheral blood smear and you see that there is reticulocytosis, but no other abnormalities are noticed.
So you decide to admit her to short stay and transfuse her, providing symptomatic treatment with analgesia as well. You also order a G6PD level, thinking this could be a potential cause. However, it comes back at a level of 9.2, which is within the normal range. She recovers well and is fit to be discharged from the hospital, though unfortunately no cause has been able to be identified. Though you note your findings to the GP to pursue other further investigations. So the patient presents back to the GP a couple days later, where the GP has had some time to run some different tests, including a G6PD level, as he's aware that this may be falsely normal in the acute setting. The result for the G6PD level does come back as reduced to 2.6. The GP then diagnoses the patient with G6PD deficiency, and she's educated about this condition and the importance of avoiding potential triggers and how to manage this going into the future. So here is a quick summary of the talk. Firstly, if you have a microcytic anemia, remember to order iron studies to differentiate the various causes. If you have a normocytic anemia, remember to look for the presence of any bleeding. If there is none, consider hemolysis as a cause, ordering a haemolytic screen, which includes a reticulocyte count, LDH, bilirubin, and haptoglobin levels, remembering that haptoglobin is the only one that is increased in the acute setting. If there is a macrocytic anemia, remember to look down the microscope to check for any hypersegmented neutrophils. And if they are present, you have a megaloblastic anemia. And remember to check the B12 and folate levels in this case. Remember, transfusion indications are very hospital and department specific, but should be considered in any patients that are profoundly anemic or may be actively bleeding. When going about trying to organize a blood transfusion, remember to first get a group and hold, then consent the patient, notifying them of the risks of the transfusion. Following this, write the order down on a fluid order chart and then notify the relevant parties. Thank you everyone for listening to my talk. I hope I have given you an effective approach to anemias and transfusion medicine.